Okay. Hi, everyone. We'll let everyone start coming in this time. Thank you for joining us. We'll get started in just a minute. Okay. Well, hello, everyone. Welcome, and thank you for joining us for today's presentation. I am Lisette Gutierrez, coordinator at the UT Health Institute for Implementation Science. This event is part of the UT Health Houston Institute for Implementation Science seminar series, which features lectures by leading experts in the field of implementation science. Registration for upcoming seminars and recordings from past events can be found on our website. The website will be added in the chat. We have a few announcements before we get started. This seminar is being recorded and the recording will be posted on our website after the event. All microphones are muted. If you have any questions or comments during the presentation, please enter them into the Q&A box, as there will be time for questions after the presentation. For those claiming CHES and MCHES credits, look for information in the chat. One moment. And now I would like to introduce the UT Health Houston VP for Population Health and our Implementation Institute's co-director, Dr. Maria Fernandez.
Hello, everybody. Thank you so much for joining us today. Today is a special day. Happy Veterans Day to everyone. And as we honor the brave individuals who've served our country, it's especially meaningful to recognize one of our own, Dr. Justin Benzer, who's not only a respected leader in our field in implementation science, but also a proud U.S. Army veteran. His service at Fort Hood, Texas, and with Joint Task Force Southeast Asia reflects a deep commitment to duty, discipline, and excellence, values that continue to shape his contributions to our field. And so, Dr. Benzer, we thank you for your service. And if you could just please introduce our speaker.
Sure, thank you. So it's my pleasure to introduce Marty Charns. Marty is Professor Emeritus of Health Policy and Management at the Boston University School of Public Health and Director Emeritus of CHOIR, the Center for Healthcare Organization and Implementation Research, which is a Department of Veterans Affairs Health Services Research and Development Center of Innovation. Marty is a graduate of Harvard Business School, where he earned a master's and doctorate degrees in business administration with specialization in organization behavior. He was one of the pioneers of applying organization theory to healthcare, especially organizational structure. He was a founding director of the VA Management Decision and Research Center, which is a unit that he founded to bridge research, policy, and practice in VA. The idea was to apply organization research to solving high priority problems in the VA. And he continued this research practice orientation as the center transitioned to a VA Health Services Research Center of Excellence. It was focused on organization, leadership, and management research. And this is where I first met Marty as a postdoc. Over the past 20 years, Marty has established himself as an internationally recognized expert in healthcare transformation, starting with the Robert Wood Johnson project, Pursuing Perfection, and including a national evaluation of the VA implementation of lean methodology through Veterans Engineering Resource Centers. He's co-authored 3 books and numerous articles, book chapters, and case studies. He was a chairperson of the Healthcare Management Division of the Academy of Management. And in 2024, he received the Academy of Management Keith Proven Award in recognition of his career achievements. I'd also humbly emphasize that my career is a small part of his legacy. Please welcome Marty Charns.
Thank you, Justin. It was very complimentary. I appreciate that. No surprise, Justin and I have done a number of things together over our careers. It's been a wonderful working relationship. And I thank him for recommending me for today's webinar and the Institute for the invitation. I also do want to acknowledge today being Veterans Day. And thank Justin and other veterans out there, all the veterans out there for their service. Justin already mentioned a few of the projects that have been sources of funding for this line of work, which really started over 2 decades ago with a Robert Wood Johnson Foundation funding to do the national evaluation of what they called Pursuing Perfection, which was engaging healthcare organizations and systems in efforts to improve quality as defined by the Institute of Medicine's goals for quality that came out of the book Crossing the Quality Chasm. And I had the privilege of working with a dozen really leading healthcare organizations across the US and learned quite a bit from those organizations that really then kicked off our development of what we call the organizational transformation model. Additional funding was then provided by the Department of Veterans Affairs through 2 different vehicles related to the QUERY program, Quality Enhancement Research Initiative. Of course, the views expressed in this presentation are mine, don't necessarily reflect a position or policy of the Department of Veterans Affairs or the US government. So I'm going to talk about 2 things today, and I actually would like to push the envelope a bit in implementation science. And no secret that I'd like to get more people engaged in looking at organizational factors involved in implementation. And so I'm first going to talk about why is organizational transformation needed, and then secondly, to present a model of organizational transformation that we originally developed and then published in 2007 as part of the Pursuing Perfection project, and then have enhanced through additional work and publication after that. So why is organizational transformation needed? So if you can humor me a little bit with the subtitle of my talk, Managing the Forest and the Trees, let's just start with looking at a tree. And let's say that an arborist wanted to improve the health of a tree, and there was new evidence for treating diseases of trees. Depending on what the arborist was trying to implement, it may or may not work. Why? Because that tree is not isolated from its environment or from other trees in the forest. So, for example, if the arborist had the latest evidence around use of insecticides and nutrients and how to prune the tree and how to give it the sunlight it needed and make sure it got the water it needed, right? Treating that one tree really can't be done in isolation. All right, so for example, if there was an insect infestation in that particular forest, you can't treat one tree and expect to get rid of the insects. It just would not be successful. And to make it even more complicated, if there were other arborists working in the same forest, bear with me, right? They would need to coordinate their efforts, right? So that the treatment of each individual tree, would be successful. So the tree doesn't stand alone. It's necessary to treat the forest. For example, insects will travel through the forest. The trees compete for sunlight and water. it's necessary to fend off the destruction in the name of improvements, such as those who might want to clear the forest for farming or for other reasons. So what we should be thinking about, and we have seen this in a number of fields, is a multi-level intervention. So it's important to manage both the forest and the trees in this example. And similarly, it's important to manage both the organization, which implementation has recognized as part of the context for implementation of an evidence-based practice, as well as individual processes where the evidence-based practice is being implemented, or individual departments or organizational units. So the idea of a multi-level intervention is related to a socio-ecological model. So I just pulled from the literature, for example, this multi-level socio-ecological model in public health, which may be very familiar to some of you, where we have at the most micro level the individual, and then we have interpersonal, organizational, community, and public practice. And I think even if we look at public health interventions, one of the things that tends to be underemphasized is this organizational level. I mean, for some people, it seems like, well, it's just going to happen. So, for example, if we change public policy, somehow we will get organizations to do the things that the policy is encouraging. Unfortunately, that doesn't always happen. Harrison and Shortell, just about 4 years ago, suggested that, and I'm going to read these bullet points, and that's about as much of text as you're going to hear from me for the rest of the presentation, but I wanted to make sure to get the point across. It's widely recognized that factors influencing organizational learning in healthcare and other industries operate at multiple levels within and outside of healthcare organizations. So they were talking about organizational learning in this particular article. I would argue that the concepts and the model that I'm presenting later in the presentation apply to implementation science, quality improvement, and organizational learning, that they all have the issue of micro, meso, macro levels and the need for multi-level interventions. They go on to argue it's particularly important to examine multiple levels of learning in healthcare because of the organizational complexity of healthcare organizations and delivery systems and their dependencies on external agencies and conditions. In Justin's introduction, he said that he noted that my degrees are from Harvard Business School. I was really either adventuresome, a leader, or not following the rest of my classmates who became captains of industry when I got interested in healthcare organizations, which was in doing my doctoral dissertation. So I was the first person from that school to study healthcare organizations. And the first thing I noted after having quite a bit of training in industrial organizations was the added complexity of healthcare organizations. So I just want to reinforce that in the Harrison and Shortell quote that I have here. They then conclude only a multi-level approach can adequately take account of the occupational diversity and interdependence of the work, interactions within professional hierarchies and between professionals and administrators, and the wide range of external influences and constraints, and how work is accomplished. So the model that they have in the article, looks at, starting from the outside, a general environment that has things like science, clinical knowledge, technology, socioeconomic and political conditions, various organizations, an operating environment that's more immediate to the organization with payers, incentives, funding, competitors, the organization itself. And I'm just going to highlight the things that they have in here: leadership strategy, IT, knowledge management, culture and subcultures, incentives, resources, and supportive systems, mid-management, including leadership, incentives, resources, going to a more meso level, the teams and units or departments in an organization, and then the individuals with their skills, attitudes, knowledge, championing, shared learning, engagements of patients in care. So both Michael Harrison and Steve Shortell have been leaders in the field for quite a long time. Michael was at AHRQ for many years. Steve is very well known, is Dean Emeritus of the School of Public Health at UC Berkeley. So just to present some arguments from this source around the multi-level intervention. So today, what I would like to focus on is these three colored circles. The organization, as one might guess, being analogous to the forest. Middle management, which in some writings has been ignored a bit, but is critical, and there is quite a literature that has grown around that, and at the team and the unit. So these three levels are very prominent in my model, my team's model of organizational transformation. Just to highlight, make another argument around the importance of transformation. Implementation science focuses on implementation of EBP in individual processes and or parts of an organization. For example, a primary care clinic. In the implementation science literature has been for quite some time a recognition of the importance of the context. What has not been emphasized, and I would argue is a logical step, is to change the context to support implementation and also sustainment. And if you think about the dynamics of organizations as complex adaptive systems, if you don't change the forces at the organizational level and you intervene at the unit or individual process level, then the forces that have been in place for years will continue to be there to push the processes back to the way they have always been. Further, you want to develop a culture where learning, where implementation, use and implementation of evidence, or if I go over to the quality improvement side, that it becomes the way of doing things in the organization. And that needs to be supported by the culture, among other things. So now getting into the organizational transformation model itself. So the model has 13 different concepts. I'm not going to ask you to take this all in at once. I do want you to see it is somewhat complex. It's something that we presented with all of these different constructs out of our work on implementing lean management in the VA. And I will go through each of these constructs and highlight some of the most important relationships among them. You probably could put some more arrows in this diagram. I tried to put arrows where the relationships were most important. It's not to say one could not talk about other relationships. So I'm going to start off with staff engagement. And one of the reasons to start with staff engagement is it's related to so many other things. I mean, just look at the red arrows all throughout this diagram. Further, it's critical in terms of changing culture. And I would go so far as arguing if staff are not engaged, it is virtually impossible to get change because you're really trying to change staff beliefs, staff behavior, the people on the front line delivering care. So this is a critical element. To highlight it, critically necessary, I noted how many arrows go to and from it. It's especially important for changing culture, and culture is central to changing culture is a central element of transformation. In fact, several authors who've written around organizational transformation put a change of culture as one of the defining elements of transformational change. So how do you get staff engaged? Well, culture works two ways. Whatever the culture is, affects people being engaged. If you have a culture where people are, which encourages people to work independently, that's going to affect engagement. And I would argue that engagement is going to affect culture because it's a way of addressing the expectations, values, and norms. Another thing that affects engagement is capability development, training, to use another word, all right, where you're getting people involved that way. And a third one, and I'll talk more about the relationships when I get to these other constructs, over here is evidence-based practices that are being implemented or other kinds of improvement initiatives. And I will highlight that next. So here, I think implementing new evidence-based practices or doing projects for improving processes is very common. Often what happens, however, go to the next slide, is that it's only conceptualized for the improvements that are made. Now, certainly there's value in the improvements that are made or the evidence that is implemented to improve the process. But some organizations only think about it in those terms. And I would argue that we don't want to just stop there, that those, let me generally call them improvement initiatives, provide important opportunities for transformation. First, it's an opportunity to apply newly learned skills. And I'll come to that in a minute with more detail. Second, it's an actual demonstration of the values and philosophy. So doing things in an abstract way has value that only goes so far. But in these improvement initiatives or projects, it's concrete. People can see, oh, this is what we really are being asked to do. This is the way that our organization wants to do things now and in the future. People also can tangibly see the advantages to the use of a new approach. And when change doesn't spread beyond a small number of initiatives, one reason is that the initiatives are right, Marty. The initiatives are not seen by the leadership, and I use leadership actually throughout the organization, are not seen strategically in this more complex way as an important part of the transformation. The next thing I'd like to highlight is capability development. And I'm primarily going to talk about this two-way arrow between staff engagement and capability development. Organizations do training all the time. We have some very good evidence from a few studies that it's really a problem when there's lots of training and people don't have an opportunity to apply it. So what I'm trying to demonstrate here in this two-way arrow between the improvement initiatives and the capability development is this is really a two-way street. Even when people are in training and they think they've learned something, it doesn't always work when they try it in practice. And so it's really important to coordinate the training activities with putting new skills into practice. The training can also contribute to motivation, and seeing the results can contribute to motivation using new skills. I do want to highlight the role of middle managers in this, who can often serve not only in a formal supervisory role, but also as mentors for their staff in learning the new skills. We often need experts in the QI literature. They're called senseis. Trying to, my Japanese may not be very good. Senseis. I won't try to do that any better. Senseis. And then simultaneously doing projects as part of the training program. So some leading organizations will design their training to have people incorporate projects as part of the program, and having the support of their supervisors in doing that. impetus to transform. So if we go back, and I'm not going to skip back on the slides, but if we go back and we think about the model where we had the immediate external forces to the organization. Often it's it's things going on in the environment. For example, a new policy, a new payment scheme, seeing what some other organizations are doing, that puts opportunity and also may put pressure on an organization to change. An important thing for leadership to do is to take that impetus, take those forces, and create for the staff an impetus to engage in the change process. So why should staff pay any attention to some of these things going on in the environment of the organization? And framing that so those pressures become an impetus is an important role of leadership. It's also, and I've seen it many times, where the impetus to transform comes from various internal sources. And I don't want to discount that, but I did want to use the external environmental pressures as an example. So some people talk about it as a burning platform. Don Berwick did that in a book. The internal motivation that is then aroused through the engagement, seeing peers and champions engaged, and then, as I said, framing the impetus to be, or the force to be motivating for staff. Culture. Early on, I said culture was important. I can put many more red arrows in this diagram. I'm just putting a few here. As I mentioned, under staff engagement, that staff engagement was quite important for changing culture. A simple description of culture is the values, norms, assumptions, and expectations about here's how we do things around here. Saying something I mentioned early on in a different way, if you haven't changed culture, you haven't really transformed the organization. There are some leading organizations where learning, the use of evidence, the use of QI is what I would call in the drinking water of the organization. The first place I saw this was at Cincinnati Children's Hospital, where anyone you talk to could talk about that organization, its culture, its commitment to quality, to use of evidence. And many people described it as being in the drinking water. I've mentioned how staff learn and are influenced to change beliefs by being engaged. That engagement often will come from the improvement initiatives, and of course, leadership at all levels. I mean, one of the things that kills any change process is where staff see their supervisors not role modeling or messaging the change. A couple comments about culture, quoting people who are much better known than I. Ed Schein has written, The only thing of real importance that leaders do is manage culture. Peter Drucker, culture eats strategy for breakfast. I took that from another writing. I've also heard it as culture eats strategy for lunch. Your preference. And Don Berwick, in the end, culture will trump rules, standards, and control strategies every single time. And achieving a vastly safer NHS, in this case, he was talking about the British National Health System, will depend far more on major cultural change than on a new regulatory regime. Right, just to highlight the importance of culture. Communication. So again, I'll just, in the larger version of this slide, just let you see the arrow from leadership to communication, from improvement initiatives to communication, and from communication to culture. And we'll just expand on this a bit. It's key to spread. One of the things I've seen all too often is that there are very successful examples of the implementation of a new evidence-based practice in an organization, but nobody knows about it except the people that were involved. So the reason for this red arrow is to say, take those successes and communicate those successes. Also, that communication is important for changing culture. So communicate in multiple ways. Have leaders talk about successful changes. Have staff communicate. Some organizations I've gone into have visual displays showing successful change efforts, videos, positive messages. And then just one footnote to this is this communication needs to be done in a way that staff can understand. Many years ago, I worked with a hospital that was implementing a patient-centered care program. And they, as part of their communication effort, they had a newsletter. Okay, this is way before the growth of the web and the growth of email, but nevertheless, it was a newsletter intended to communicate with staff about the change program. And after they were doing the newsletter for some period of time, they checked in with staff to say, did you find this helpful? What have you learned through the newsletter? And what they found was that the staff thought it was a bunch of jargon. It wasn't written, even though they thought it wasn't written in a way that would really be interesting or in some ways even understandable. And it was more of a turnoff than it was a way of effectively communicating and engaging. Informed decision-making. Using evidence. Well, of course, using evidence is part of implementation science, the implementation of evidence-based practice. It's important that staff not only learn the use of evidence and do that in what I called the improvement initiatives, but it's also important that there be an organizational capability to produce relevant information. So Intermountain Healthcare, who actually was one of the 12 organizations back in the Pursuing Perfection project had, and I hope still has, although I haven't been out there for a while, had built in to the way the organization functioned that the leaders of different clinical areas sought evidence. This was part of their core responsibility, was to, with help, scan the literature for evidence that might improve practice in their given clinical area. But then the other part of it was doing small tests of change. Or you might think about the ERIC strategy for implementation science of audit and provide feedback. So how are you going to get the data to be able to see how the change is actually affecting practice, and better, how it might be affecting outcomes? So this is something that's inherent in learning organizations. It's something that has to be built, though, because it's very difficult to maintain a manual system of collecting data and providing that feedback. So then it becomes difficult to sustain the new data, to sustain the new practice. So another piece of the model that is important to think about. Integration. One of the first things that I saw when I worked for a computer firm back in the days was how departments did not cooperate with each other. And this is very, very common in organizations. Highly functioning organizations are able to address it effectively. But each department has its own set of goals. There may be superordinate goals, but each department is focusing pretty much on its thing. And think about the articles in the implementation science literature, where in the discussion you see something like, the implementation was not successful because Department X would not get engaged or cooperate. It's something that is at the organizational level and something that needs to be addressed so that the culture of the organization is supportive of the cooperation, coordination, integration across departments. And it may be difficult, especially in the beginning of a change program, if there's a history of lack of coordination, of cooperation. But it is necessary to address, both for transformation and for the ongoing functioning of the organization. Problems may be encountered, they may be surfaced while people are working on implementing a new practice, and they say, oh, as we analyze the patient flow here, the other department really needs to engage. And here's where concretely we may surface some of the problems. I'm putting my consultant hat on rather than my researcher hat on when I say you may not want to address this early on if it presents a challenge to early successes, because I believe that a large-scale change process needs to pick up momentum and needs to build on early successes. So therefore, when you're looking at it at the organizational level and saying, well, what things might we work on early on? You want things where the potential of difficulty of working with other departments, which typically means a more complex implementation, doesn't drag down or limit the success of some of the early efforts. Alignment. Alignment is in many articles about change. How do you choose the projects to work on? How do you put in place the systems to provide the measurement, the feedback? And what is it most affected by? Well, it's leadership. There's an article in the organizational psychology literature, literally from 5 decades ago, that's called On the Folly of Rewarding A While Hoping for B. And the article points out that we do it as parents with our kids, we do it in organizations, we do it in society. And the article argues that we want to align the rewards and incentives with the behavior that we're trying to achieve. Oops, sorry, that was unintended. And I think a wise person who was leading the VA's lean transformation said, well, maybe we don't want to worry too much about alignment again in the beginning of a change process, that getting staff engagement, getting staff engagement is more important in the beginning than alignment, because engaging staff is so critical to the transformation process. So she suggested that choose efforts that the staff really support. I've seen many organizations that go after costs in their change process, and that is not the highest priority for clinical staff. Much more important are things directly affecting patient care. So go first for things that will help staff engagement, and then over time, pivot to things in the QI literature called True North, but pivot to things that are more aligned with the overall goals. Patient engagement, I'll just say a couple things about it. Allows staff to adopt the patient's point of view and uncover taken for granted aspects of care, improves participation of staff, increases transparency for the organization, but it requires a real focus of time and resources. I'm highlighting the impetus to transform that can come with patient engagement as well as its effect on staff engagement. And one quote, this is from a leader in a change effort. We were in this room and we all there with our own perception of where the problems were. And then to have one of our veteran patients come in and give input, an employee said, we had no idea that's how the patient was seeing it. So it completely changed the way they were thinking about what they were working on. The quote is from one of our studies, and I have seen this over and over again in different organizations. I cannot underemphasize its importance. And finally, leadership. Why did I leave leadership for the end? Not because it's unimportant. I mean, look at the number of red arrows, how it affects so many other things. And you could put more red arrows in there. It's central to transformation. It affects everything else. As I mentioned earlier, framing the change, turning the pressures into an impetus to transform, role modeling, a combination of top-down and bottom-up efforts to lead. I recently finished a systematic review of the published literature, empirical literature on organizational transformation in healthcare. And it was published this summer in Medical Care Research and Review. You know, as we looked at the success of transformation in those articles, one of the things that came through very clearly was top-down efforts rarely work. And I go back to the issue of engagement. Frontline staff have a lot of knowledge, a lot of skill, and are important and are critically important as leaders. And also, I want to emphasize the key role of middle managers. There now is a well-established literature on that, their key roles in managing change. Okay. We have a few minutes left if there are any questions, and I'll leave this slide up with some of the citations.
Thank you. Thank you so much, Marty, for a great presentation. There are a few questions. Let's see if we can get through a couple of them. One question is, what role does coaching and mentoring play in staff engagement? Identifying change champions, opinion leaders, and knowledge brokers. I guess that's one of the answers.
So definitely a critical role. And there's several, using the word role in a different way, there's several different roles mentioned in that question. You know, there are managers, formal leaders, informal leaders, champions. It's something that potentially could be expanded upon, as I was talking about the training and how training and engagement and actually using the new skills and in that the necessary mentoring and support, whether it be from a formal supervisor, from an expert or a consultant in the organization. Eventually it comes from other staff. You know, as the capability of the organization develops and staff help not only people who they've worked with for some period of time, but remember their new staff coming into the organization with some frequency. And so how do we bring those people on board in terms of this is how we do things here? And we have some formal training for skills, and we have support and mentoring around the development of the individual and their use of new skills. I think I'll stop there.
Yeah, and then we might have time for one more question, and I chose one that I think represents a couple different questions. Is it possible to change culture from the bottom up? Meaning, can staff prompt change? What about outsiders? Can the community push an organization to change?
I'm thinking, so the answer is yes, but I think limited. One of the questions that I'm sometimes asked is, how do we get an organization to engage in change when it seems like the organization's senior leaders aren't interested? And because those people control resources, you know, and set so much of the tone, I think it's very difficult to be able to even start change in more than a small part of the organization without senior leadership support. I think it could be done if the staff can get a supervisor, their middle manager on board. But then you still have the challenge of spread and the challenge of trying to convince the executive level of leadership to provide the resources, to push the change further. In the systematic review, we had one article of a community mental health, actually 3 community mental health organizations that were trying to change. There were many people who really supported it, but they engaged the community, but neither the community nor the staff in this particular article were able to overcome their traditional working relationships in a professional client relationship. So I don't see how something like that, which involves such a core level of change, could be initiated from the bottom up. I would say it's bottom up and it's top down. And so maybe it originates at the bottom, but unless you get the top, I really have my doubts.
Thank you. And it's interesting that you mentioned middle managers, because there's a couple other sort of questions about middle managers and what should they do and where do they start. And I think I heard you saying that their interaction and working with the leadership is probably one of the best ways to go.
Absolutely. And I mean, think about a negative situation where staff go to training and then they come back and the middle managers don't have a clue about what they did, are in an awkward situation of not having the opportunity to learn the skills that their staff did. And sometimes if they're uncertain, and they feel threatened. So bringing the middle managers not only as passive actors in the change process, but as active supporters of change and supporters of their staff. One of the people who's written a lot about this is Sarah Birkin. And so I don't have any of her things on this list of citations, but it's someone, if you're interested in the role of middle managers in change and implementation, specifically, I suggest looking at her work.
Great, great. Well, thank you so much. We're out of time. I want to thank you, Dr. Charns, for a phenomenal presentation. Thank you, Justin. And again, happy Veterans Day to everyone. And please look for our additional seminars in the future and the recorded seminars online at the website. Thanks again, everybody.
And thank you.